Hey Facebook, wanted to share an interesting day of evals yesterday. So I want to share two evals that I saw yesterday and see what your thought process would be with these two patients. So one sounded like a probable ACL tear, maybe MCL meniscus. Construction worker fell off a ladder about 6 weeks ago. Thought it would get better by just sitting at home and not doing nothing. So he finally went to the doc, primary care, referred him here. So that's the first one. Second one is a patient that was recently diagnosed with ALS and already experiencing loss of sensation in the bilateral lower extremities, loss of strength, and severe issues with muscle endurance with walking. So thought process wise, what is the difference between these two patients when you evaluate them? What are your goals for them? What's your treatment strategies? How do they differ if they differ at all? So here's what I did with them, and they were both the same. So with both, I used the same functional screen. Obviously had to tweak it a little bit because the ACL would not do a single leg squat, would not do heel walk. And the ALS patient had a lot of difficulty with anything balance-wise, could not do just a standing bilateral calf raise, could not do standing bilateral dorsiflexion, rocking back on his heels. Doing things like that was so frustrating that he started to break down and cry. So I cut his functional screen short because I already know what I'm dealing with him, and I needed to move forward. So treatment-wise, what are you going to do for these patients? You have one patient who is most definitely a neuro patient, who's your ACL patient, and you most definitely have another patient who's a neuro patient because he has ALS. So every single patient that you see in an outpatient orthopedic clinic is a neuro patient. If you don't understand that, you can't evaluate them, you can't treat them, you will not get long-term or immediate functional results because you're going to chase symptoms like swelling and pain and loss of range of motion. All of that is secondary to neuromuscular dysfunction. And as soon as you figure out that every single patient that you see is a neuro patient, then you will actually have clarity when you move from their evaluation to their treatment, and you will have a streamlined process to get you from their treatment to their therapeutic exercise, which is all going to be neuro-based because your treatment was all neuro-based. And when you're evaluating, you're looking at neuromuscular function and dysfunction. So if you can't wrap your head around that, you will not go anywhere with your career. You'll go take dry needling courses, you'll take K-tape courses, you'll take whatever the next fad is course because you're going to chase symptoms. Until you get down to the root cause of every patient's issue that's coming to see you, which is neuromuscular inhibition, you will not get long-term functional results that are based on science. So treatment-wise, put these guys on the table. The ALS patient was more right leg involved than left leg involved. Trunk wasn't too bad. Upper extremities, not too bad. A little bit of stuff there, but I didn't want to waste a whole bunch of time there because I've got 35 minutes to get him evaluated, treated, patient education, and send him home. And he actually lives in Alabama. So I'm going to see him today and then probably have to follow up on Zoom to update exercises, and then he'll be back in town for Christmas. So I've got to bridge the gap from now until Christmas. So right leg, quads, hams, glutes, all inhibited. Severe inhibition, and that was quads, hams, and glutes on the right. Severe inhibition of the dorsiflexors, plantar flexors, foot inverters, everters bilaterally. So work on all that stuff. And as I'm working, as I do the first 2 to 3, if you've seen me treat patients or you've taken the course, the shift, you already know that I don't tell them what I'm doing while I'm doing it. I just let them feel the difference between inhibition and facilitation. So by the time I get to the third muscle, which was probably vastus lateralis, he finally, because I would ask after I treat it, does that feel better? And he'd be like, yeah, I think so. First one. Second one. Yeah, that does feel better. Third one, what are you doing? How did you do that? I couldn't stop you last time. So that's the reaction you get when you get immediate results that are based on science. So then I explained to him what I'm doing, finding muscles that are inhibited, turning those muscles back on. You have a nerve problem. I'm treating the nerve-muscle relationship so we can get as much strength and get you to start doing things with your home exercise program to increase your muscle endurance. That's our focus. We're not going to get rid of ALS. We're going to clean up all the secondary and tertiary issues that are happening because of the compensation. So get through his lower extremities, a little bit of trunk, work on pyramidalis for toe touch. His toe touch increases by about 6 inches, which obviously impacts his gait and his balance. So get him up and walk, and he's like, yeah, I can actually feel my muscles working in my right leg now where I couldn't feel them before. Squat, he can squat and get up. Stand up out of the chair, I forgot to tell you, his sit stand out of the chair was 0. He had to push up with his arms. Now he can sit stand from the chair. Dorsiflexion, still pretty limited. Standing dorsiflexion, plantar flexion, much better. He can actually do some calf raises. So get him a home exercise program, mostly focused on isometrics for glutes, glute max, quads, rectus fem, vastus intermedius, vastus lateralis, hamstrings, all of them, dorsiflexors, plantar flexors. So focus on those, and then a little bit of functional standing, marching, squatting, heel toe rock, hip standing abduction, that kind of stuff. So how is my thought process different when I get to the ACL patient? It's the exact same. I'm going to do a functional screen. I already told you he will not do a single leg squat. He cannot go into dorsiflexion and knee extension on the involved side. Gait's pretty unstable, but not terrible. Do a little bit of a pivot shift standing, and he's actually not too bad. So put him on the table. Pain with full flexion. Will not go into terminal knee extension, will not let his leg rest on the table. Within 15 minutes, he's got terminal knee extension, hyperextension, no pain. He's got full strength quad facilitation, no pain. He's got full knee flexion. And as I'm going through this, he's laughing and saying, how did you do that? So these are the reactions when you get functional outcomes. The reactions you get when you treat symptoms is after they get up off the electrical stimulation or the heat or put the K-tape on or do whatever symptom modification you're doing is, oh yeah, that feels better. I don't care if they feel better. That is never the goal. What I want them to say is, I can do things that I couldn't do when I walked in here. I have control. I have balance. That's functional results. So get him up off the table. Full squat, does a single leg squat, walks on his heels, no pain. As far as special tests, because remember, he was referred by his PCP, has had no imaging, has not seen an orthopedist. So I did a little bit of half-assed special tests to begin with. I did more special tests at the end. Why? Because now he's back to baseline. He's been limping for 4 to 6 weeks. He's still got swelling that's been there for 4 to 6 weeks. So why in the world would I do special tests at the beginning of the visit when he's going to fail all that? So if I do special tests at the end of the visit, now Lockman and Drawer, pretty good. Got an endpoint, so I'm happy with that. Valgus stress, doesn't like that. Bounce home, actually good. Now remember, he couldn't even go into resting knee extension to begin with. Now I can do a bounce home and he's fine. So my take is he's probably got a grade 2 MCL sprain. Load him up with exercises in the transverse plane. So isometrics to begin with, then squats, lunges, transverse plane work for his home exercise program. So as you can tell, these are the same issues: neurological, neuromuscular dysfunction. If you treat that, your thought process is the same with every single patient that walks in your clinic. I don't have to change my thought process for a Medicare patient versus an athlete. I don't have to change my thought process for a post-op patient to somebody who's coming in with idiopathic low back pain. I don't have to change my thought process with whatever imaging they come in. It doesn't matter. I'm treating the root cause for every single patient. So every single patient individually is going to be unique and different, but the thought process never changes. So just want to give you that scenario. If you came up with 2 different scenarios, you would have went 2 different ways with those 2 patients. You probably would have ended up with 2 different things, and neither one would have let them walk out of the clinic with immediate functional results. So when you're ready to get functional results, if you're ready to get a streamlined thought process with every single patient, get results with every single patient, make your job insanely easy because it makes sense, and make your patients get results visit after visit after visit, hit me up, join the MemberShift. It's time to change your career.